Jessica Crawford is a senior manager and lead for Health Systems Group at Village Reach. In her 8 years there, she's developed and led a broad portfolio of health innovations focused on health system strengthening and improved performance at the last mile of the health system, particularly in terms of supply chain, human resources development, mHealth, and community health program. I think she's going to speak about all those things tonight. Jess has over 13 years of experience in the design, implementation, and evaluation of health system programs, both in the U.S. and abroad. She's led projects in the following countries: Malawi, Tanzania, and Mozambique. She helped establish the Village Reach Malawi country office, served as the first Malawi country director. And prior to joining Village Reach, she worked in Health Services Administration at the University of Washington, where she focused on quality improvement. And then she served as a community health educator in Tanzania with the Peace Corps. She has an MPH in Health Services and an MA in Policy Studies, both from the University of Washington. And her BS is in Cell and Molecular Biology, and her BA is in Sociology, so she likes to get double degrees. The title of her talk is on the screen, and let's join me in welcoming Jessica Crawford, who came all the way from Seattle
via Bozeman, that's right. Well, hi everyone. Thanks again for welcoming me. It's exciting to talk to you about some of the work we're doing at Village Reach. It sounds like you have a really cool lecture series, and he was just telling me about some of the previous talks. So hopefully this can be just as stimulating as Ebola and Ned Geiger. Those sound pretty cool. So some of this will be a repeat for those of you that I just spoke with. But a little bit about Village Reach first before I sort of dive into our methodology and theory of change, so to speak. So Village Reach is a nonprofit, global health focused organization. Our headquarters are in Seattle, Washington. We have field offices in Malawi, Mozambique, Tanzania, and the Democratic Republic of Congo. And then we also have a number of engagements globally. So we work in primarily sub-Saharan Africa, although very recently we've started a program in Pakistan as well. So this is some of the places where we have either field staff located, or we have engagements with some of our bigger partners. So Village Reach's whole focus is on strengthening the health system at the last mile. And so when we say last mile, we're really talking about the lowest level of service delivery of the health system. So that can be any point at which a patient meets a care provider. And our mission is to serve the underserved. So we're working often in very remote, very isolated settings, and always with the last mile in mind. And we're also looking at systems. So we strengthen systems at the last mile, or systems that can support the service delivery at the last mile. So our work is not to provide healthcare. We don't have any healthcare providers delivering care. Our work is to support the systems that enable that health worker to provide care at the last mile. So in our work, in all of those countries that you saw just a second ago, at the last mile, there are very, very similar challenges that we come across. A lot of them having to do with poor infrastructure, poor information, poor human resources abilities, poor human resources, in terms of sheer numbers as well as the support for those human resources, all limiting access to healthcare. So our mission, as you see right there, is it's been through a number of changes since I've been at Village Reach, but it is to save lives and improve health by increasing access to quality healthcare for the most underserved communities. Interesting note, so I was the Malawi country director for 3 years. I was living in Malawi. And underserved, when you do an autocorrect, comes out as undeserved, which we had printed on our business cards for the longest time. So careful when you write underserved. They're just not autocorrect. It's very embarrassing. So our areas of focus, as many of you heard earlier, are, again, on the systems that support the delivery of care. So in order to provide care, you need medicines and you need commodities. In order to, give medicine, give a vaccine, you need syringes. So a lot of our effort focuses on supply chain, strengthening the supply chain. So again, it's not the delivery of that vaccine, but getting the vaccine to the last mile, or getting it to the point at which it's delivered to the patient. Information and communications technology. Information flow is critical to resource allocation, to making decisions around where and when resources are needed, whether it's people or medicines. Human resources for health, a lot of our work is both in adding to the numbers, so developing more human resources, as well as strengthening the human resources that exist through supervision, mentorship, capacity building. And then our work has a lot of emphasis on bringing in private sector where private sector makes sense, learning from the private sector in how to deliver care or how to build supply chain systems in an effective way. And then our work, as you'll see, I'll get to our theory of change, but our work is always with scale and sustainability in mind. And so with that, we need to focus a lot of our efforts on advocacy and change management so that institutions, donors, policymakers consider the last mile in their approach and in their investments. And so our work to demonstrate what we've learned at the last mile and what we know works to solve the systems of the last mile can be part of the policymaking process or part of the donor investment process. Our methodology at Village Reach is really a 4-stage process. So all of our innovations, and I'm going to talk about some of our innovations, but all of our work really sits at this learn and develop stage, where our teams who work at the last mile, cross sectors, so private sector, technology experts, public health experts, we work to understand what some of the challenges are, innovate with our colleagues, with our partners on the ground, develop strategies, test those strategies, go back and learn some more, keep testing them, and then the ones that we find really work and are effective and we have a great evidence base for, we work then to promote and support those. And that to us is that advocacy piece, that how do we get others to take on some of the work that we've seen to be effective. And so this 4-stage process really guides our thinking. Village Reach always has the goal of scale and sustainability for our innovations, and it's not through us. So we are an organization of about 100 people globally, and we see the biggest bang for the buck is when other institutions, whether it be policymakers, large-scale implementers, or donor institutions, when they start adopting some of our learnings and innovations into their thinking and their strategies, that's when we win, and that's what we get excited about. So tonight, I'm going to talk about 3 specific innovations that have all made it through this process, so that you can get a feel for what it takes to get there. Scale and sustainability is not easy in this field. So I will talk about how each one of these programs made it through the different stages, and how we've come to this thinking at Village Reach and really brought it forward in our work. So the first one is going to be our immunization supply chain work. Now it's called Next Gen ISC, so it's got a really fancy name, Next Gen Immunization Supply Chain. Then I'll talk about Health Center by Phone, which is actually called Chipatala Chapafoni, which means Health Center by Phone, but in Chichewa. And then I'll talk about our pharmacy assistant training program. So, Next Gen ISC. When you work in the field of global health and you work specifically at the last mile where we work, and you see that there is Coke everywhere, really, Coke or beer, whatever the local beer is. So it could be, it could be a Heineken product, or in Malawi, it's oh my gosh, what's it called? It's I'll come back to it. It's terrible. They're everywhere. They're at the last mile settings, and then you go to the health center, and they don't have antibiotics or an essential medicine or essential commodity for providing care. And you think, what the heck? Why doesn't this work? And that's such a common question. We hear it time and time again. Well, Amazon can do it, so why can't you do it in a public health setting? And in fact, it's a lot more complicated than that. Mismatched incentives, all sorts of challenges. You're working with policymakers, so we all know that when you work with policy, evidence, rational thinking is not always what drives people to make decisions in our policy world. So the question: why does Coca-Cola reach rural communities when vaccines, medicines, and supplies do not? So this is a type of road that's very familiar to us in working in last mile settings. Part of that infrastructure challenge. How do you overcome terrain like this, even worse than this in Ethiopia, as Peter mentioned earlier, in rainy season and floods? How do you get to those last mile communities? And some of the constraints when we're talking about supply chains that are Ministry of Health driven or Ministry of Health run, because in our world that is who operates a public health supply chain. They own all of the medicines, they buy all of the medicines. And they're responsible for distributing all of the medicines. It means that ministries of health manage fleets of vehicles. It means that they have supply chain managers in the Ministry of Health to determine where medicines are distributed based on very little information, because there's no information system that allows them to have an understanding of where medicines are needed and in what commodity or in what quantities. And some of the very structural challenges have to do with the way that supply chains were designed originally, based upon the administrative levels of a Ministry of Health. So the way a budget is structured, so that you have a national level, and then the provincial level owns their budget, and then the district level owns their budget, and each tier of government is responsible for from their level down for the distribution of commodities. And this sort of decentralization is in supply chain is really inefficient, because it means you need, in vaccines, you need cold chain at all of those levels, you need refrigerators, you don't have power at a lot of those facilities, so it doesn't make sense, but that's where it's responsible. You need vehicles at all of those levels in order to be able to just distribute from there. So in the supply chain world, it really doesn't make a lot of sense, but it's the way it was built when supply chains were being built. When EPI, when the Expanded Program for Immunization was launched in the 1970s, this is what the supply chain made sense at the time. And it worked in a lot of ways. We got vaccines out to a lot of underserved populations. Vaccine coverage rates went from 20% to upwards of 70, reaching 80% nationwide in a lot of countries. That's actually a lot better than it is in Seattle. So, I don't know if you know about vaccine coverage rates, but we have a really bad reputation where we live for having poor coverage rates for different reasons. Like I mentioned before, there's just a lot of flying blind. You're not really sure where to send vaccines or in what quantities. You don't know how many vaccines are already there at the facility. It's overly complicated. There's no one actually trained to do supply chain management within the ministry. So you're asking clinicians who are trained to provide care to providers to instead do supply chain management, which is it doesn't make sense because you don't have a good supply chain manager, and then you lose a very talented clinician in the process. So a lot of just structural, systemic challenges in this public health supply chain realm. And all of that, leads to a number of challenges in getting the right number of vaccines available. When we first started our work in Mozambique, we saw a lot of problems with, women who often walk a number of hours to get to the facility to have their child vaccinated, and if there's no vaccine available, they're turned away, which just erodes trust and confidence in the health system, and then they're unlikely to return. So a number of reasons why it's so critical to have that vaccine available, and essential medicines for that matter. So this is a statistic from the the Effective Vaccine Management Assessment, which is what UNICEF and the WHO recommend that countries go through when they are, as they're running their immunization programs or their EPI programs. The EVM across the board, almost all the time, even now, still the EVM results show that supply chain is one of the weakest performing functions in reaching immunization coverage, reach an ideal immunization coverage. And it's going to get worse. It's going to get worse because there's new vaccines coming to market. They're bigger, they're bulkier, and they cost a lot more. And so countries are going to be even more concerned about making sure that those vaccines that they procure actually reach their intended targets. So the vaccine supply chain is already a challenge. It's already broken. It's built on administrative levels that existed 30 years ago. It doesn't make sense anymore, but it's policy. It's difficult. It's really difficult to change. And it's just going to get worse, and it's going to get harder and harder for countries to adapt. So our work is to build more efficient and stronger functioning supply chains in immunization in particular. We have gone through this process a number of times in a number of different countries, and we've found that essentially there are some key characteristics to a highly performing supply chain, that it has a holistic system design that incorporates all elements that are necessary for a supply chain to operate. So that's people, that's equipment, that's information, and that's a continuous improvement mindset. So how do you build a supply chain that takes all of that to account within a government? And our approach is system design, is a holistic system design, and we work directly with governments in order to put effective system designs in place. Now, this is my colleague, this is her favorite slide, because system design it actually makes you have to think in a new way. This is because these are systems that have been in place for so long, it's hard to get people to see something different. And so here, this is really an innovative approach, but I'm afraid we can't consider it. It's never been done before. And that's the barrier that we get when we're working with governments, because if you don't have, oh, it's new, it's exciting, but if you've never done it, then we can't do it either. So it's hard to get enough momentum and enough evidence to really change people's minds. So I'll go quickly through our experience in Mozambique, but essentially our system design, this is the original one, which I've kind of already talked about. This really does take a lot. So essentially our redesigned, or our system design, resulted in an informed push model. This is very common in supply chain. So it's like a vendor-managed inventory. So let's say the vending machines out there, you don't have someone here who's checking the stock and ordering those stocks all of the time to make sure that the vending machines are fully, have the Skittles or whatever it is you want in them. It's the person who's responsible for the Skittles who comes and does manages that stock level. So they come to your vending machine, they count, they refill, they replenish what you need. And so that's the type of model that we've implemented in Mozambique and that we've built off of for other in other countries. So a vendor-managed inventory in public health supply chain world is called an informed push model, which means that essentially at the central level, you're responsible for managing the stock levels at the periphery, but you have to have information in order to do that, and so collecting that information and pushing the vaccines, but you're making the decisions around how much vaccine gets sent to everyone, versus a poll model where someone would, at the health center would say, I need 50 vaccines of 50 polio vials this month, and I'm going to order those from the next level. This is someone at the central level making that decision based on information that they have at the lower level. And we all, in addition to that, we put together a dedicated team of people who did rounds of distribution on a monthly basis. So then when they would go to a health facility, they would deliver, they would top up the number of vaccines, they would provide support and supervision to the staff who were there, who were also working in isolation, so they could give them some pointers on, vaccine administration, or check their numbers, or check their refrigerators, and provide cold chain maintenance at the time. And at the same time, they're collecting critical data to come back with and put that into an information system so that at the next time they do their delivery, they have a lot more information. So seems like a really easy, simple change. And it had huge impact. Oh my gosh, I didn't know this was an animation. Sorry. Huge impact, actually, just by making some small changes to the supply chain. We saw coverage rates of the vaccination of DTP3, which is the sort of standard indicator for a fully immunized child, moved from 68% before we were working to 95% in our region. We saw vaccine stockouts on average of 80% to sometimes very infrequent vaccine stockouts, so 1%. Cold chain functioning, so meaning the refrigerators weren't broken. Huge impact that this, by making vaccines available all of the time, we saw a really big impact. And then it also was more cost effective and more cost efficient. So you would think that with this type of evidence, it would be so compelling that a Ministry of Health would say, oh yeah, absolutely, we need to put in place those changes. It's less expensive and it's better functioning. And yet, 12 years later, we are still working on this nationwide in Mozambique to get it implemented as a national change to their system. And that is part of the advocacy and change management that we've learned along the way and we're much better at now. But that was our original pilot project. We operated in one location, and we operated as a typical NGO operates, where they do everything. And you have a lot of money from the Gates Foundation, so you go in and you do an awesome pilot project, and you show some really great, dramatic impact results. And then you're like, okay, government, here you go. Do it. And that just doesn't work in our field. And it's what all of the NGOs do. And so really, we learned a lot from that. We spent the next 5 years working to do policy change within Mozambique to be able to adopt this type of a supply chain model. And we're little by little getting there. We're still working in Mozambique. We're in 8, it's called the dedicated logistics system. They're in 8 provinces out of 12, so it's moving, it's getting there. But most importantly, what we've managed to do with this is those dramatic results and our work now with the government operating it has influenced Gavi, so the Global Alliance for Vaccines, has influenced our funders, the Bill and Melinda Gates Foundation, has influenced UNICEF, and has influenced WHO. And so now, this type of system design thinking is part of the Gavi supply chain strategy, it's part of the Bill and Melinda Gates Foundation strategy, and UNICEF is our global partner. So now we're working in Zambia, in DRC, in Guinea, in Malawi, in Pakistan, to do the same thing, to do a system design. We do modeling, we do all this supply chain geek stuff, and then we work most critically with governments in order to implement that. So that is Next Gen IC. Do you usually pause for questions, or should I just? Any questions?
Sure, you can pose a question.
Before I go to the next one?
See if there are any questions right now. Actually, I have a question. When you evaluate the new system, because there are a couple of elements to it, which was more important, or how can you tell which was more important? The professional workforce, supply chain workforce, or the routine deliveries? How can you separate out the impact of those two?
Yeah, it's a great question, and it's a question we get asked all the time. one of the, so we recently, the Gates Foundation has recently asked us to lead a sort of a research agenda around understanding what works in supply chain and what doesn't work in supply chain. And our first effort was to look at, well, what has everybody else researched? You know, what do we know what we know? But that's just a small province in Mozambique. What does our sector know? And there's nothing out there to be able to tease that level of information. You know, we know these are the holistic components of a supply chain, and then we know that if you do all of those, you're gonna have a much better performing supply chain. But to be able to answer a lot of those questions, and this comes up in our modeling too, so we do supply chain modeling, and there's a ton of questions around, well, what if we just replace a refrigerator here? Or, well, we can't really level jump or, you know, skip a district storeroom because that district pharmacist needs to get his per diem in order to go, you know, so there's these policy issues then, and so if you just did this, then how much is it going to impact your results? And we just don't have that level of information, unfortunately. So we've just recently hired a new research and advocacy director who is based in South Africa, and she is leading the charge in getting us a ton of information. So she's building a whole research agenda. She's bringing a community of people along with her. A lot of those stakeholders that I just mentioned, Gavi, WHO, UNICEF, the Gates Foundation, and some of our colleagues who work in immunization supply chain, like JSI and CHI, along with her to build a research agenda so we'll have much better responses to those questions.
I'm fascinated and not surprised at how long the advocacy work has taken. And I'm wondering whether you have any sense yet whether what becomes more important to the bureaucrat. Is it the promise of Gates Foundation money? Is it if local people are telling him this is what works? Is it because there's an NGO that just keeps pounding on his door?
Yeah.
What seems to make the change?
Yeah, great question. And it's actually a little bit different in every place. So one of the main questions on my colleagues' research agenda is what do decision makers care about the most? So exactly what you're asking. In my experience, it has, you know, by working with Gavi and working with UNICEF, all the countries we're working in are Gavi eligible, so Gavi subsidizes vaccine purchases. So a country who wants to have, you know, who is a low-income country and can't afford these, you know, a number of vaccines that are in the schedule, Gavi subsidizes. Basically, they sit between the pharmaceutical companies and the governments, and they subsidize the procurement of vaccines for countries. So countries need Gavi funds in order to have vaccine programs for their population. Gavi also supports system strengthening. So Gavi, until very recently, didn't. They just provided, you know, procurement subsidization, and then they realized, well, we've bought a whole bunch of vaccines, and they're not going anywhere, and they're not reaching the people that they need to reach. And so Gavi has recently entered into some health system strengthening grants to countries. So because we work with Gavi and we've influenced the supply chain strategy from the beginning, countries can adopt that system design process through Gavi grants. So it helps to have funding to do it, definitely. And then we've also learned in some of our other work, which I'll talk about here, that government engagement from the very beginning and government ownership is absolutely critical. So it's not just, I'm an NGO and I have a ton of money and I can do a great project and you should do what we did. It's let's build this together. Let's meet your needs. Let's see how we can provide you with assistance, either financial or technical assistance to build a stronger system. And that ownership and that buy-in has led to some of our later successes, which haven't taken as long to get government ownership. So the next one is Health Center by Phone. Chipotala Shakafoni, or CCPF. So I'm just going to call it CCPF from now on. That's what we call it. Oh no. I have all these animations I didn't even realize. So a little bit about Malawi. I like to talk a little bit about Malawi because I lived there for 3 years. I miss it. But so Malawi, you know, is one of the poorest countries in the world. So I think according to the World Bank, it was like third from the bottom or something, which is really, really terrible. in terms of financial situation anyway. High rates of maternal and child deaths, very low human resource population, or ratio, as you can see, 2 doctors and 28 nurses for every 100,000 people. I don't have to cite the challenges, but a lot of challenges, particularly in last mile settings. And one of the challenges is a real just lack of access to information. I like to start talking about CCPF from the context of myself, because that little adorable creature back there, that 2-year-old, is my daughter. And when I was pregnant with her, and during her first year of life, I got on my phone every single day and searched for information about her health, about is this normal? Should she be doing this? Why can't I sleep? Just so many questions that you have. And women in last mile settings don't have access to that information. There's no internet. Even if they do have access to internet, how do you even begin to search? Even as an internet savvy person myself, it's hard to know what you can really trust as information and what you can't. So we built this service, Chipatala Shapafoni CCPF. It's a hotline. It's basically, it's call a nurse. You can call directly, toll-free, from any phone and talk to a person on the other end who will help you understand whether or not what you're experiencing is normal and you can care for it at home, or if it's something that you should really be concerned about and you need to take yourself or your child to a health facility. It is staffed by health workers. They're equipped with touchscreen devices, so these are, they have protocols built into them, so it's decision tree support, it's built off of an electronic medical record. It helps them to diagnose or to understand what it is that that patient is calling about and make the appropriate decisions while also collecting a lot of information about the caller. And then attached to the call center is a mobile messaging platform. So it's you get, based on your week of pregnancy, your week of your child's birth, you get information about that week. Here's what you should know. Here are the vaccines you'll be getting when you go take your child to well child visits. Here's what you should expect when you go to your next prenatal care visit, etc. So CCPF started in 2011 in a rural district in the south of Malawi, Balaka district right there. It was a Gates Foundation pilot project, but we learned our lesson from our work in Mozambique, and so we worked with the government from the very, very beginning to design and implement this. So working with government at every level, as well as with the population. So working with women, working with rural women, what do you want information on? How do you want to access information? And so really build the program with that level of buy-in and partnership from the beginning. The pilot project went tremendously. We got some really great results from it. And we have been trying to scale it nationally ever since. We've worked with through partnerships, so working with other institutions to incorporate the hotline into their program offerings. And as you can see, it has taken 6 years, a little bit less, but still a really long time to get the program to national scale. So this year we're scaling nationally, and a lot of that success is due to our first and foremost partnership with the government. It is a government-owned program. And in addition to that, we have had some really amazing partnerships. So one of them is with Airtel, which is the largest telecom provider in Malawi, who now provides the service free of charge. So it used to be always free to the clients, but Village Reach paid for it, or our donors paid for it. And now it's free entirely. So Airtel now pays for all calls and also markets the service. So they're able to reach all of their clients, all of their subscribers with information about the service. So that level of buy-in from a mobile network operator is actually unheard of in our line of work. So we work a lot in the mHealth sector. Everybody wants to know how to do this because telecoms are one of the biggest barriers to scale and sustainability when you're working in mHealth because it's really expensive. Mobile in Malawi it's just unaffordable for people working in the population that we want to reach with this type of information. So we've also, while we're scaling geographically, we're scaling in the scope of our offerings, so what we talk about or what we provide information on. It used to be maternal and child health, and now we have an adolescent health aspect to it. We provide direct nutritional support, and this comes from our partners. This is the need that our partners see on the ground based on what they hear from their communities and their constituents. We need more information. We need adolescent girls to have access to this information as well. So that's where we've grown. We had, like I said, we had really great results. This is some of our monitoring data. I'll kind of skim over this, but we know this is from the pilot project. In the beginning, when we were only working in one district, we were getting on average about 1,000 calls per month, so we knew that it was already being well used and it was well liked. We had a independent evaluation done because this was a Gates Foundation project, so they like to fund evaluations of their projects, which is great. We saw that callers or users of the service had some really tremendous improved knowledge and improved behavior. So our callers were more likely to use antenatal care within the first trimester. They had early initiation of breastfeeding. They used bed nets during pregnancy. A lot of these things that donors in particular are really interested in seeing, but we were really excited about because we knew that our service also had impact. So we knew it was popular. We knew intuitively that this was a service that's really needed, but we also now know that it has impact in the way we wanted to see. We thought mobile was going to be a barrier. Mobile phone ownership is really low, so 36% of households have a mobile phone. But what we found was that access to mobile phones was really high, and that was through phone sharing. That was people. It's toll-free, so it doesn't matter. Anybody can use the phone to call. So we found that mobile access was not a limiting barrier. And then, as I said, that's like moving into this promote and support stage. So here we are, we have this great project. We learned a lot during the process of developing it and starting to scale it up piece by piece. So how do we promote and support that? And really the work with partners, Ministry of Health at the forefront with the MNOs, and with some of the implementing partners in Malawi. We recently were awarded with a 5-year USAID grant to fully fund the ministry because it was included in the ministry's health sector strategic plan and the ministry's budget and the ministry's ask to their donors. So these were huge wins for a program like this, and we're so excited about it. So this year, we're scaling nationally. We're transitioning ownership to the ministries so that we're just providing some technical assistance until it's fully functional under Ministry of Health ownership. We're making sure we've put some investments into place so that we're transitioning a good package of services. So call center infrastructure, we're upgrading some of our technologies, some of the, working with the ministry to develop a staffing plan, human resources, and then we're going to look to where we can do this again. And that's it for CCPF. So I'll pause. Yeah.
Have you talked to Airtel about doing this in any other countries, or are they thinking about it, or would they entertain that?
Yeah, a little bit. We're actually talking to Vodacom in Mozambique right now because a lot of other telecoms have come to us since Airtel, and in Malawi, other telecoms have been like, oh, we want to do it too. So we're talking to Vodacom in Mozambique, and then Airtel in a couple of other places. Yeah, it really depends on who the managing director is there and what the country. So in Malawi, it was a nice turn of events that led us to that partnership. So Airtel had been operating something called Dial-a-Doc that the president had actually asked them to do, and it wasn't going very well. They had a lot of barriers, mostly with government engagement, and so. They were being demanded to provide a service, but the service that they're providing just it's not working. And so we came along and said, well, hey, we can help you with your service. Let's partner. We can bring all of the things that you can't, and you can bring all of the things that we can't. And this is a really great partnership. And so the managing director there said, yeah, this is great. Let's do it. So it had to do a little bit with the Malawi specific context. And now what's really most important is, for a mobile network operator, it's, how much attention am I getting, how much money am I getting, because people want to have their Airtel phones on because they can access the service now, right? And so they can use it for other aspects. And so, looking at where Airtel or other telecoms are having, maybe some churn issues, or where they're looking at their portfolio of offerings, and if this might make sense to them.
So I'm thinking about Kenya where they have the M-Peso and they're used to using the phones. In terms of scaling it, could you not have call centers anywhere? And talking about East Africa, as long as you've got Swahili, you could cover Tanzania and Kenya and a lot of other countries.
Yeah,
So that you could take your one call center, staff it up in one place, supervise it, and then make it available.
Yeah, and definitely. And part of our model is, again, to work with others to do this. So we are talking with there's actually some University of Washington faculty who are running or looking at starting a hotline in Kenya. They have some other mHealth programs there. So we're talking with them to try to, help them with what we know works and doesn't work. So really just that sort of promoting advocacy. And then at the same time, part of what we really believe to be successful about CCPF in particular was the Ministry of Health ownership of this. And so making sure that this was a trusted source for people in the community, that they knew that they were engaging directly with the Ministry of Health, and it was an extension of the health system. And so for us, it was critical that it be in the Malawi, and that it be Malawi driven and Malawi specific. But certainly, and there are call centers, there are private sector, there are technology centers that you can call right now that exist, who tried to come into Malawi actually and open up the same thing, and the ministry shut them down because they said, nope, we've already got ours. So they do exist, and they are operating their fee though, so not quite reaching the same populations that we care about.
So it seems to me like the most expensive part of that whole system is the trained people that handle the phones, the hotline workers. Who pays for them?
Right now, it's a mix of us and the ministry, and in the transition, it'll be all ministry. We're actually looking at models right now with them to do this as a rotation for nursing students. So that's it's attached to the training. It's attached to the call center is being moved. So it's still in Balaka District Hospital. It's being moved in to Lilongwe, to the capital city, and it's being attached to one of the hospitals there, and training as a training hospital. So they're looking at having it be a staffed, a sort of internship.
Yeah, Liv, maybe you could elaborate on that, because we do have some nursing students here. I think they would find that interesting. So, if you were to take nursing students, you should probably have some kind of a supervisor there at the same time, right?
Yeah. Oh, yeah. Yes. And we have right now we have 3 or 4 nursing supervisors, nurse supervisors. And they've been written into the Ministry of Health budget, operating budget to maintain their salaries. So definitely. We currently have, the hotline workers now are a mix of community health worker level trained staff, and then nurses, and then we have physicians on call that we can triage calls to. But the ministry, under their ownership, only want nurses. They don't want community health workers. So we're looking at creative ways to help them staff a hotline, which is how the nurses in training came up. Although we're writing that memorandum of understanding right now.
You guys have any follow-up questions on that?
This is a good idea. Big cool opportunity.
Yeah, I think that the other piece of it that I understand now that I didn't understand before is that you have the physicians on call too. So that seems to be important, that if you have a more complex question, that you have somebody that you can go to for that.
Again, the percentage of really complex questions is really low
It is really low.
compared to all the calls which can be handled in the protocol.
Yeah, exactly. Which was why the Dialodoc didn't go very well, because they had physicians on call, but they were getting called all day long for a lot of really minor questions. And so we took their, so we have their physicians now, and it's way better. They get very much fewer calls now, and only the ones that are really, that should be triaged to physician's answer. Any question?
What is the availability of professional training there as far as, like, are they training their own nurses and physicians around that area, or is that something that,
In Malawi?
yeah, how do they go about that?
Are you go to South Africa, or are they?
No, they're trained in Malawi, which is a great lead into my next topic, which is pharmacy assistant training program in Malawi. So I'll talk about some of the training institutions, but there are, they have a lot. I mean, there's a lot of great training institutions in Malawi. They have University of Malawi. They have a lot of private institutions. The place that we worked for the pharmacy assistant training is Malawi College of Health Sciences, which is the only accredited institution to train lower level cadre of human resources. So I'll go right into that. Yeah, there's a lot of Christian. In Malawi, the largest provider of healthcare services is the Ministry of Health. And then second to that is Christian Health Association of Malawi, so CHAM. So it's they have service level agreements, so a lot of the staff are actually Ministry of Health staff, but it's a very large provider of care services, but it is private. So. Okay, so the reason I went to Malawi was to launch this program and to start our country office. This is a pharmacy assistant training program. So before we started doing this, there were no pharmacy assistants, so we started it. We started a pharmacy assistant training program. But to put this into context, when we started the program in 2012, there were 5 pharmacists in the country, 5, for the whole country. And that was, working within the public health system. Certainly there were pharmacists who ran, private pharmacies and sold medicines and things, but in the public health system, there were only 5 pharmacists. There are pharmacy technicians, so people who get basically a diploma, a 3-year post-high school training, pharmacy technician. And there were very limited numbers of those too. I think it was like 100 maybe. The vacancy rate was 80%, so just very, very few pharmacy personnel. And all of them, pharmacists and pharmacy technicians, were all at either central hospitals or at district hospitals. So they were at higher level centers, which makes sense because that's where all the top tier drugs are. That's where you need pharmacists and pharmacy technicians. But it meant that at no health facility in the entire country did you have anyone trained in pharmacy. So that meant that no one was doing dispensing. Literally, you would go to the storeroom, and the person that you would go to the pharmacy at the health facility, and literally the person who gives you medicine is a security guard or a ground laborer, somebody who is hired to do sweeping and things like that. I mean, really, no one is trained to manage medicines at the lower level. So this causes a lot of problems, you can imagine. Not just in terms of pharmacy, ensuring that, as a patient, you're getting good information about the medicine, or that you're getting the right medicine that you've been prescribed, and that you're not getting medicines that, contradict each other. But at the lower level of the health system, you need someone to manage your stock as well. You need someone to manage your storeroom. You need someone to order, to fill out your supply requests and reports. So from us, as a supply chain organization, as sort of our DNA, when we were working with the Ministry of Health, we said, well, what do you need to really solve some of your supply chain problems? And they said, we need people. We need people to manage our supply chain, and we need people at the lower levels of the health system to do that. So we started the pharmacy assistant training program. So basically, this was a direct request from the Ministry of Health. So we skipped forward past the pilot project. Let's demonstrate results and get Ministry of Health buy-in. At that point, this was a Ministry of Health request. They said to us, we need to do this, so can you help us do it? So we kind of jumped forward a couple of years there. So it's a direct partnership with the Malawi Ministry of Health. There's only one training institution accredited, so we worked with them to develop the curriculum. We had faculty from the University of Washington in the School of Pharmacy come with us and help to build the curriculum with the faculty at the College of Health Sciences. It's a 2-year certificate program. It's practicum based. It means that you spend half of your time in real settings. So in your first year, you spend a semester working at a district hospital under the direct supervision of a pharmacy technician. And in your second year, you spend 5 months, a semester, at a rural health facility. And we've seen tremendous impact from that, both in terms of this readiness of the person to do rural service, to really work in these settings, but also immediate impact on the supply chain and on the ability to manage medicines and dispense medicines, the quality of pharmaceutical services as students. So just huge success in that. We also had an impact evaluation. It was led by the University of Washington, and we saw that pharmacy assistant students increase health-seeking behavior and access to medicines. So the impact evaluation looked at communities that surround health facilities that have students doing their practicums to assess their health-seeking behavior. And we found significant impact on children with fever going to get medicines at the health facility and then getting medicines at the health facility. So an impact in terms of community trust and confidence in the health system, as well as their ability to get the medicines that they want to get and they need to get. They improve the information quality, they improve service delivery. I mean, it's just tremendous. And then at this last one, which I really care a lot about, is that pharmacy assistants, even as students, decrease the burden on clinical health workers. So when you're looking at human resources and you want to get, deploy good quality human resources, by having a pharmacy assistant, you're actually saving the time of all of the clinicians who would normally be doing that. So you can imagine at a health facility where we've seen work, that if the health center in charge, whether it's a medical assistant or a nurse, doesn't trust a security guard to dispense the medicines, they're going to hold the critical medicines at their desk, right? The ones that cost a lot of money, so the ARTs or the vaccines for that matter, they'll hold them at their desk and dispense them directly, which means that it's a lot of time to do that. And to package and to prepare all of the medicines to get them there. So saved a lot of clinical time. We did a needs assessment because we, again, with our model, we wanted to get out, we wanted to hand this over, we wanted to transition this for scale and sustainability. So we said, well, in our last year of the grant, where we have funding to manage the program, how can we ensure that the Malawi College of Health Sciences is going to continue to do this in our absence? So we focused on a lot of capacity building at the training institution itself. And then we spent a lot of time doing advocacy. And for this one, it didn't take us a whole lot of effort because it was one of those things that just spoke for itself. We took the Ministry of Health senior level pharmacy staff with us to the health facilities to see the pharmacy assistant students and the amazing work that they had already done in our health centers. And they said, yes, that's what we need. And then other health center in charges, when they would have a student intern at their health facility, they would call their district health officer and say, we need one of these students at our health facility. So the demand for this cadre was just immense. So the advocacy effort just really didn't take a lot because it was something that everyone wanted to see happen. And we were just we were really the facilitators of that. And so to me, this is one of our greatest successes. So now, I'm just gonna skip through these. So now the Ministry of Health has built this into their training program. So it's now a Ministry of Health and institutional training program. We've been asked to accredit a new training institution because the Malawi College of Health Sciences just can't get them out fast enough. So we're working now to help another training institution get the accreditation so that they can train pharmacy assistants as well. Donors have already started sponsoring, so USAID has sponsored 2 cohorts since we stopped sponsoring students, and they have already committed to new cohorts. Global Fund has committed to cohorts. So we have just an amazing, we're now seeing, this is our success. We are now seeing this program go. And we have been able to hand this one over much quicker. So that is the end of my talk. Just bringing it back to the beginning to say these are the 3 programs that I talked about, and this is the process that we've gone through to see them reach scale and sustainability. I could talk for 3 or 4 more hours on all of the ones that haven't gone through this process, because we have a lot of them that are in this stage and this stage as well. So, I'd encourage you to check out some of our work on the website, like drones that I was talking about a little bit earlier. There's a lot of cool, exciting stuff we're doing, but these 3 programs, I think, help really sort of demonstrate the way that Village Reach works. These are our most, I would say, most successful ones to make it all the way through the process. That's it.
It's really a lot of excellent food for thought here, and some really creative, innovative ideas, and really reaching out to places that need this kind of support, and finding ways to make a difference in ways that have been untouched before, but really have a lot of potential. So I'm very excited about this. I hold off for a minute, Chris, because I have a follow-up question though on the pharmacy assistant program. So I think it's great that you focus on lower level staff training. I think that's most of the time ignored by the agencies that are involved in international development and international development training. They like to look at the top levels. Maybe once in a while they get down to the middle levels, and very rarely do they get down to the lower levels in terms of training. So I think that's a really important insight, and I think that you demonstrated how valuable that can be. And I think that there's another advantage to that, which is it's an employment generator. There's so many people in Africa who are trained at university levels, and then find that they're overqualified. They can't find work. So you're really training people, giving them the basic skills so that they can find a semi-professional position, and that will be a career path for them. So I think there's that dimension to it too, the 2-year certificate program. So anyway, my follow-up question is, what I wasn't clear on is, what's the difference between a pharmacy assistant and a pharmacist? What can a pharmacy assistant do that a pharmacist can do?
Yeah, sure. They have, I'm not going to use the right word, but in the establishment of the different levels, the different cadres, they have a clear set of criteria that they can and can't do. It has to do with the different types of drugs that they can handle and that they can manage and that they can dispense. So a pharmacy assistant would never be able to, without going through appropriate training, to be able to handle narcotics, for example. So those are much more controlled drugs that would only be managed by a pharmacist, and therefore only managed by an institution that has a pharmacist on staff. From a very simple level, I'm sure there are a lot broader sort of scopes that define them.
Is this certificate likely to be a way in which you can improve your career, grow in your career to become a pharmacist?
Yes, there are upgrade paths. They call them upgrading. There are ways that you, so as a pharmacy assistant, after a certain number of years working as a pharmacy assistant, you can qualify to take the 3rd year of the diploma program, so that you don't have to repeat, but you can take the 3rd year of a pharmacy technician program. So yes, there are upgrade paths available. And it was really, when we built it, it was our donor at the time, was not the Gates Foundation, it was the Barr Foundation, and they were really interested in career path. They actually wanted this to be a career path for community health workers, which the ministry had a lot of, we didn't get it through because the ministry didn't want to lose their community health workers. But for the students who are now graduated, I think they have to do 2 to 3 years of rural service before they can qualify, but yeah.
Well, they're kind of comments, but I'd like to hear what you have to say. I think it's really interesting that even though the Ministry of Health asked you to put together this program, once you got it started, it still needed a demand from the people in the villages or others to force the Ministry of Health to come back and then provide the services that they said they wanted in the first place. And you were sitting right in the middle, which is the second comment of anybody that ends up doing any overseas work or thinks about it, when you pack your suitcase, don't put clothes in, just put patience. Because it takes an awful long time to see this stuff come to fruition.
It's so true. Yeah, it really is true. And I was there. I launched the program. I took it all the way from the beginning to the end. It was my baby. The first graduation of the students, I got really teary-eyed when I was speaking, which I was totally shamed and shunned for, but I was really proud. Yes, it took a lot of effort. There were leadership changes within the ministry. There are some other challenges that we had, but really what it came down to was convincing the ministry to prioritize this. So yes, they wanted it and they supported it, but to prioritize it in their ask to partners and donors. And that's really what the challenge was.
Is there one more question? Yes.
So is that program a pharmacy assistant program or a pharmacy technician program? Because in the States, I know that pharmacy technicians only require like a GED or a high school diploma and some minor certificate to be a pharma tech.
It was in Malawi context, which is built largely off of UK schooling system. It is a certificate. It's a 2-year after high school, basically. So it's like an associate's level degree. And it is the way that it's a certificate diploma degree, and it's assistant technician pharmacist. So this was an assistant program, and we started it at the College of Health Sciences. So the certificate itself, it existed in Malawi early in the 1980s, and so we weren't starting from scratch. We were building off of something that had already existed and then had been, had stopped, and all of the pharmacy assistants were upgraded to pharmacy technicians, because at the time that's what they really needed, were more advanced people, and then coming back to this realization that, well, pharmacy technicians and higher level, going back to sort of what Pierre was saying, is like higher level trained people, they don't want to go work in this rural area. They can get, better jobs in South Africa or, which they do. They leave a lot for, actually, Zimbabwe. Pharmacists from Malawi go to Zimbabwe for work. So so this one, to make a long answer longer, was a pharmacy assistant certificate level training.
Well, we've run out of time, but I know that Jessica's willing to stay for a little while longer and meet individually with any of you that would like to talk to her individually before she heads back to Bozeman, and I'm keeping my fingers crossed that the roads are clear for the ride back. So let me just mention to you, Jessica, that over here we have students who are part of a group called the Global Grizzlies. And they are, this group of Global Grizzly students go to Africa every year in the summer and contribute their skills. They are going to Uganda this year. Am I right about that? Yes. And they're all excited about that, and they've been very, very good about coming to the lecture series and learning from people like you about what to expect when they get there. Over here we have students from the MSU UM nursing program, and they've been very good about coming to these lectures and also interested in global things, which is great. I mean, I'm really happy to hear that our nursing students would be interested in learning more about the global things that we have. And then we also have several of the other students scattered around here from my class who you met with earlier. So there's Chris, for example, and Samantha. I want to make sure that they get some recognition too. Some of the students here, how many of you are pre-med students? Okay, so you see we also have a fair number of pre-med students who are in this Global Grizzly Club and so forth, and so they are involved as well. So I'm saying all this because I just want the people on TV to know that I'm really proud of what the University of Montana has to offer among all of you in terms of the kinds of things that you're doing and the way in which you are committed to doing some things in the global health area. And I really appreciate that, I respect that. I think that's a message we need to get out. that this is one of the things that the University of Montana has to offer. And, so tell your friends about it as well. So join me in thanking Jessica for coming all this way. Next week, we're going to keep up this focus on remote rural areas. And so we're having a talk on dental hygiene work in rural settings.